Good morning, good afternoon, good evening, and good night, friends and colleagues from across the world. Today, I have the privilege of having the famous Dr. Michael Pikos as a guest on our podium hour today. Welcome, Dr. Pikos.
Thank you, Kianor. It's a pleasure and honor to be part of your program.
Yes, I've been following your work since I got into implantology 15 years ago with ICOI, and kind of wanted to introduce you to the audience for those who do or may not know you. There may not be too many, but let's go over your bio, Dr. Pikos. He's originally from Campbell, Ohio. He attended Ohio State University, where he graduated summa cum laude and Phi Beta Kappa. He also graduated with honors from the Ohio State University College of Dentistry. Dr. Pikos completed an internship at the Miami Valley Hospital and residency training in oral and maxillofacial surgery at the University of Pittsburgh. He is a diplomat of many organizations, including the ABOMS, the American Board of Oral Implantology and Implant Dentistry, diplomat of the International Congress of Oral Implantologists, and a fellow of the American College of Dentists. He's also the recipient of the 2006 Aaron Gershoff Memorial Award from the American Academy of Implant Dentistry, and the 2005 Saul Schluger Memorial Award for Top Educators. I saw you just got another one from the Periodontist Association, and the list is rather long. He's an adjunct professor, Department of Oral and Maxillofacial Surgery at the Ohio State University, where he's an alumni. And he's also a courtesy clinical assistant professor at the Department of Periodontology and Department of Prosthodontics at the University of Florida College of Dentistry, and several other appointments at different universities, including Greece and Alabama. He's also on the, if that's not enough, he's also on the editorial board of the following journals, including Implant Dentistry and Sight Dentistry, Journal of Aesthetic and Restorative Dentistry, and the Journal of Implant and Advanced Clinical Dentistry. So Doc has placed more than 30,000 implants since the early days in the 80s. And he has been involved with CT technology along with the foundational principles of prosthetics and biomechanics that dedicate the ultimate success of comprehensive implant rehabilitation. He is also an author and has trained our colleagues all across the world and all the inhabited continents. And that is more than 5,000 of us in all the 50 states and 43 countries. Dr. Pikos maintains a private practice, which is limited exclusively to implant surgery in Trinity, Florida, which I had recently the pleasure and honor to visit and tour. Wow, Dr. Pikos, one of the most credentialed individuals that we have had on the show. What is your motivation? 40 years now of educating?
38 years, actually, 38.5 to be exact, but motivation, honestly, Kianor, it's just a passion for enjoying what I'm doing. I always wondered as a kid, whoever would tell me they loved their work so much that it was not work, it was kind of their play. And honestly, I can say that today it's been fun, and I'm actually having more fun now than even before. Like anything else, you learn more as you go along, you continue to learn, and the fun becomes in being able to not just absorb and incorporate, but to pass on to our colleagues. And that's kind of been the real fun for me, wearing two hats. One is a clinician, certainly, that I enjoy very much, and also equally enjoying the other hat, which is the educator hat. Yeah.
So implant dentistry is a very desired scenario. As you know, 1 out of 3 Americans are missing at least one tooth or more. And it's a huge opportunity for our younger colleagues to get involved in. So you have trained thousands and thousands of doctors. I know there's been a lot of specialists amongst that crowd. Have you seen a particular pattern of the younger guys that come in that want to overcome their fear and want to get started? It's only 10% of our GPs doing it. What have you observed any kind of pattern?
Definitely, there's been a trend, probably the last 12 or so years at least now. I've been able to appreciate it. My institute, with all the courses that we've offered over these 31 years now, I would say in the last 12, even maybe to 14, 15 years, the trend has been loud and clear. More and more restorative-based dentists wanting to learn surgery, even above and beyond basics. And those are the folks that I'm able to work with and train, and we'll get the most out of the courses because we teach it at a more advanced level than the basics. So understanding the basics first and foremost, and then coming to us, those folks get the most out of the courses for sure.
So on the basic side, what would you, what sort of courses would you recommend? And then on the advanced side, what courses would you recommend for someone that wants to get into it?
Well, basics I think are important from the fundamental standpoint, meaning to learn the fundamental principles and having and placing implants at least a few hundred before they come to see us. There are a number of courses that are out there certainly now that are available to them. There's the implant pathway with Dr. Justin. I mean, there's so many. AID has the Maxi courses. There are a number of opportunities for young clinicians to get started. No question.
So when they start coming to your courses for the more advanced stuff like the Allon X, things of that sort, in my personal opinion, over the last 15 years, as I learned more about oral surgery and implantology, I had to work less and I was making a bigger impact on people's lives. Where does it start for Allon X? I placed several hundred implants before I started getting into that space, as you alluded. But at what stage are they ready to come and see you to learn more about full arch prosthetics and full arch implant placement and guided surgery and Allon X and those type of things?
That's a great question. You know, I would say that the full arch immediate implant reconstruction case type presents the greatest challenge, I think, for everybody, and myself included. And I really did a lot of homework before I got involved, some probably 12, 13 years ago, with the case type that I do today. And it really, I would say we could look at two different types of these cases, meaning one we can fully guide, the other doesn't lend itself to that. But either way, I would say this, that the foundational principles that need to be mastered are numerous. In fact, I would say the following, and that is that the most challenging kind of case type that we look at today is the full arch immediate reconstruction one, because it really involves not just implant placement or the so-called Allon X. I think that's a term that's been tossed around now for quite some time, but I actually trademarked, believe it or not, just because I've had a number of things borrowed from me over the years, if you know what I mean. But on Allon XYZ is really where it's at, meaning X is number of implants, Y involves bone grafting, and Z is soft tissue grafting, because all components are necessary, in addition, of course, to the main one that drives everything, as we know, which is the prosthetics. But if one, in fact, is going to focus on, let's say, the surgical arena, then in my humble opinion, one has to master not just implant placement, but also bone and soft tissue grafting, because the so-called graftless solution, I think, is a really bad misnomer, with all due respect to Nobel and others who have continued to talk about that phrase. And I say that with all due respect because I have a number of colleagues that are involved, of course, with that exact methodology and moniker, if you will. But as I see it, you know, we're still grafting, maybe not graftless, but graftless. Yes, I think it's important to understand and appreciate. If you're going to follow your cases, then you can appreciate better what I'm saying, in that if we don't address bone and soft tissue, there are enough built-in problems that are going to occur with these cases, and especially the more advanced ones that involve zygomatic implant placement. These cases lend themselves to even more morbidity. So unless we take a true prophylactic approach to these cases, I think we're in for quite an awakening here down the road. And I say that again with all due respect because we do follow our own cases now. It's been 10, 12 years that we're involved, and you get to see patterns, certainly. And like anything else, even with all my grafting cases over the years, 38 years and counting, there's nothing more humbling than seeing some of your patients coming back and you scratch your head and go, now who did that? And you realize, well, it was me. And then you think twice, like, okay, now what was I thinking? But back in that day, that was kind of where things were at. So you learn from your own cases. And I think that's one of the beauties of being able to practice as long as I have been. So I learned from my own mistakes and complications, certainly, et cetera, et cetera. But the long and short of it is, for full arch immediate reconstruction cases, these really, really are the toughest and the most challenging, also the most rewarding. I will say that. I don't mean to sound like a Debbie Downer. It's just that to make a short story long with regard to your original question, I would say that anyone wanting to get involved with full arch immediate reconstruction type cases, be they guided or not, really has to spend adequate time with placement of conventional implants. How many, I couldn't tell you exact number, but at least several hundred would be my number that I could just throw out for sake of discussion. And then it gets even more intense from there, because it's not just, again, about implant placement, but certainly appreciating bone and soft tissue. And of course, the overwhelming factor, as you well know, is the restorative end. One has to have a real good handle. If you're surgically based in particular, then it's even more important, because placement of these implants, of course, everything is predicated on that begin with the end in mind kind of phrase that's been thrown around for so many years, but truly is applicable to everything that we still do today in implant dentistry.
So are you saying more prosthetically driven preparation before you actually conduct the surgery?
Absolutely, yes. Yeah, absolutely. More than anything we do, because the error factor here with some of these cases really can place a patient into a really tough position where there can be some irreversible damage being done, such that will render them to more of a truly situation where even for example, in a maxillary case, that sinus grafting would be precluded. So therefore, really the only last resort would be zygomatic implant placement times even 4. So a quad zygoma patient could be the result of implant failures, conventional implant failures, et cetera, in the upper arch as an example. Sure.
Wow. So yeah, you also, I had a brief interaction with you. In some circles, you're known as the world's leading clinician or authority in bone biology. So I urge the audience to listen very carefully. You said the word boneless. That's something completely different than obviously without grafting of any kind. It's more minimally invasive. So you have shifted your opinion over the years as to what the patients want. They want more minimally invasive type scenarios. So what do you mean with boneless?
Well, graftless really is what I had said. And the term graftless solution, again, I think is a misnomer for many reasons. And that is because, for example, in our full arch and maxillary cases in particular, there are a number of, I'd say at least 30 or more % of the time, I'm grafting either extraction sockets, extraction defects because of pathology, et cetera, and even partially some sinuses, depending on the specifics of the case, in conjunction with implant placement, be they conventional, tilted, as well as zygomatic implants. And then from a soft tissue perspective, no question that X number of these cases require that for good attachment. Otherwise, especially, for example, a hypoplastic maxilla, which we'll see a number of these patients where the maxillary arches, the alveolar bone is so thin that, yes, we can place implants, say our smallest diameter, Pikos system 3.5, that we can still use multi-unit abutments. But if we can see translucency of the implant body through the bone, that lends itself down the road to what? Dehiscence, more or less, especially with a thin phenotype. So what I'm saying is, rather than just extract, place implants, place the prosthesis, call it a day, and be real excited about the whole case, if we're truly following our cases, 3, 5, 10 years out and greater, we're going to see issues. And I saw them in my own cases, even in posterior maxillary reconstruction cases where sinus grafting, but not paying attention to ridge augmentation. In my early years, I've done sinus grafts since '89. And I'd say for the first 10 years, roughly, I was unaware of the problem that would occur later in those very thin ridges, meaning following my own cases, once again, I would see time to time dehiscence, literally bone loss and tissue loss to the point of, if I had lack of attachment, then here's a periimplantitis situation, which could have been avoided had I paid attention to ridge augmentation that I'm become very sensitized to. So in a nutshell, those cases need to be not just sinus grafted, for example, lateral wall and fully pneumatized sinus, but also lateral ridge augmentation is necessary for long-term quote unquote success. So that really piggybacks off of, the fact that craniofacial growth we know continues in all of us till we die, not just to the growth spurt. And I think we were shown that nicely by our colleagues, 2013, I believe, Daftari and Bahat showed that beautifully, that, craniofacial growth, it's there. So therefore, I witnessed it and experienced it without anyone telling me about it because of the cases I just shared with you in the posterior maxilla. Now move that to the pre-maxilla and throughout the maxilla for that matter. So in our full arch cases, again, a hypoplastic maxilla, place the implants, pay no attention to a thin phenotype and a relative lack of bone volume. And I promise you, with time, there will be morbidity that won't be fun. And that's why, honestly, I love social media as you do. But the problem is that how many cases are presented on any given chat line,
Rarely.
Maybe the last 6 months, maybe 3 months ago, maybe 2 weeks ago, last night, this morning. How about live? And that's all great to teach to a certain point. But how about let's have a format with maybe a 5-year follow-up minimum, and then let's make it maybe 10-year, and then let's make it 20, and then at that point, I think we'll lose most everybody, if not sooner. And then let's go to 30 and 35 years. Now we're bearing our souls and we're showing everybody what's reality. And again, not to sound holier than thou, not at all. I've got my share of complications over the years. Absolutely, yes. And in fact, in all of my courses, I bare my soul and show 90% of my complications are my own that I share, not just somebody else's. And I think that's important to be very transparent and not have any filters as can occur with social media, as we know. So if we're showing complications now via social media, now that's a teaching modality, absolutely, that's invaluable. And there are a number of clinicians that do that, and I really respect them quite admirably for what they're doing, because that is how we teach the best, certainly from our complications. So in a nutshell, to get right back to your original question, the importance of hard and soft tissue grafting for these full arch cases is absolutely critical for long-term success and predictability of our cases. I really absolutely stand behind that 100%.
You bring up a very, very good point, Doc. Social media is not the place to actually learn surgery. You've gone through several things that you have done at your facility in expanding. I understand you now have a workshop, you have a main lecture hall, main surgical suite. And you got some courses coming up, which I, having placed implants now for 15 years, I'm looking forward to take your full arch course for immediate restoration. Tell us about this expansion you did in Trinity and why, and what do you envision happen at the Picos Institute?
Sure. About 7-8 years ago, I decided to just have my own facility rather than have more or less leasing a hotel space and or administrative building that we did for a number of years at a nearby hospice from our Palm Harbor office, which worked quite well for the time frame, and we would beam over the live surgery. It became apparent that it would be way better, more convenient all the way around for everybody involved to have my own facility. And thus we have as you were able to see here just this past month, a really wonderful place that lends itself nicely to education. We've got 4,000 square feet of lecture hall, discussion, what have you, our main auditorium, and an adjoining area for our exhibitors. Typically, we have 10 to 12 per course. We have then a separate large surgical suite that is able to be visualized directly from the lecture hall. And of course, on our large, wide 3x1 screen, there are 3 videos that are occurring at once during our live surgery part of our courses. And then a separate facility, another 2,500 square feet that's just behind our existing teaching facility, and that is for hands-on training only. And we're real proud of that one because we also have a 3x1 screen there. So this all has come together quite well to really more or less allow me and my team to share our clinical experiences in I think, a very, very top shelf, state-of-the-art facility that lends itself quite well to teaching and to being able to interface with such amazing folks like yourself from all over the country and all over the world. It's been fun. It's been a lot of fun.
It was amazing. The tour I did of your facility was one of the nicest I've ever seen. I understand you're doing these on a monthly basis, and then once a year you bring the best of the best to Florida to also hold a annual symposium. Is that correct?
That is correct. Correct. We have between 10 and 12 courses per year, which include our fundamental bone grafting course, which is a 4-day course, single tooth and full arch reconstruction, and everything in between. It's a very comprehensive, intensive 4-day course on bone grafting. That's my signature course that I started out with 31 years ago. And then we have a separate sinus grafting course of 3 days that's also intense, where we cover not just lateral wall, but certainly crestal sinus grafting, along with complications, etc., live surgery, hands-on, 3-day soft tissue course, as well as now full arch courses have been teaching for the past 10, 11 years.
The one for the full arch, you have one coming up in January, right?
That is correct. We actually have two. And the mid-January one is our fully guided full arch immediate reconstruction course that we do in conjunction with InSequence. I've been involved with this particular company now since 2009. And it's really an amazing protocol that we're able to utilize for about, I would say, 75% of all of our patients, because the other 20 to 25% really don't fit into the category of allowing you to fully guide the cases because they're more extreme, involving, for example, pterygoid and zygomatic implants, etc. But the fully guided approach is a very wonderful one, and that is really been a labor of love, so to speak. My team and I have helped develop this protocol within InSequence over these years, and it's morphed into a very predictable modality for addressing patients that have bone in zones 1 and 2, as opposed to lacking bone in either of those zones, which of course then become the extreme case. But as I've shared with all my audiences, I think it's really important that one understand and know and be doing full arch brain guided surgery, if you will, before they attempt our full arch guided kind of cases. So in a nutshell, this course is very unique, and it is coming up in January, and we're excited to host another group of individuals for this training, because we're showing, of course, not just the surgical, but the prosthetic phase of treatment and the lab. We have all three involved, and it's a very unique course. I will say that, yes.
Very good to guide. That's very good how you set it up. I was very, very impressed, and I have had a lot of colleagues that have gone through your curriculums. I started my curriculum with Dr. Mish back in the day, but it started all with listening to you and bone biology and many main podiums. I highly recommend you guys look into this. And basically, Doc, that wraps up my questions. I look forward to seeing these cases. I understand you're going to present a couple of cases today and take us through that, correct?
Yes, that would be a privilege here, as I mentioned early on, and would like to just share a few cases and explain a little bit about this guided methodology and how it works. Sure.
Wonderful. With that said, I'm going to go ahead and disappear. I'll be in the background, and I'll see you for the Q&A session.
Perfect. Thank you.
Thanks so much.
All right. So again, I thank Kianor for that great introduction and the banter that we had here for these past 20 minutes or so. Again, it's an honor and a pleasure to be part of this program. What I would like to share with all of you during this time frame is basically just a few cases explaining the methodology of these fully guided full arch immediate implant reconstruction kinds of protocols that we've followed now since 2009. And then just close out with a comparison of this protocol versus conventional conversion protocols, if you will. So I've been in practice now for some 38 plus years. It's been a lot of fun to be practicing as an oral maxillofacial surgeon. I will say for the past 26 or so years, I've focused in one arena, and that's implant-based surgical reconstruction. That's all that I do, giving up hospital-based privileges and all the orthodontic surgery, et cetera, I did over the years. I'm fortunate and blessed to have a great team of clinicians that are with me. And we have under one roof 3 specialties. We have Dr. Blundell, Dr. Hernandez, and Dr. Anderson as 3 surgeons that practice with me. And then we also have my 2 kids, Lindsay and Tony. They are periodontists. And then finally, Phil Hedger, our prosthodontist now for the past 5 years. Under one roof, we have 3 specialties. So we can do quite a few things that we would not be able to do by ourselves. And one being, of course, full arch immediate reconstruction cases from start to finish, including an anesthesia team that involves my wife, who is a nurse anesthetist. It's been some 31 years now for the Institute. As Kianor mentioned, I've thoroughly enjoyed the ride, having a number of alumni, as you see, from all 50 states, 43 countries. It's been fun. I have enjoyed it, and I think enjoy it now even more than ever, being able to interface with so many great people from all over the globe. This is an important disclaimer in that in this digital age, we can grow bone, grow soft tissue at a push of a button. Not doing that. As you can see here, maybe some of the images have been cropped or rotated or resized, but none of them have been altered or manipulated. I think that's really important to share with all of you. So with that said, just looking at our fully guided approach with the in-sequence protocol, it's been quite an adventure over these years. This particular protocol has developed into one that is so predictable today and so accurate. I can only tell you that it's been quite an interesting evolution. I give so much credit to the folks at in-sequence for what they're able to do on an ongoing basis. I can share with you these particular phrases. Of course, we're all familiar with them, and they all represent more or less an analog approach to our full arch immediate cases. And there's really nothing wrong with that approach. We know it's predictable. It's been going on for so many years and continues to be the majority, or represent, I would say, the majority of case types that are done. However, as we know, this is an analog approach and a conversion denture approach. We know that. And if we look at what a reactive system is all about, I would say that non-guided surgery fits into this category without question, because we're responding to more or less a number of parameters. In fact, we're reacting to these prosthetic parameters as you see here. There are a number of items that we literally play off of and just sort of have some guidelines, yes, but not necessarily ones that we have defined so well and that are so reproducible. And we're also reacting to different surgical landmarks, of course, as well, intraoperatively, versus a proactive system where we're acting in advance, if you will, of a particular future situation, and we're pre-planning. We're working almost like a flight simulator, where our brain doesn't understand the difference between reality and virtual. So therefore, we can, in advance, in the virtual world, plan our case completely from both a surgical and a prosthetic perspective. Now, that said, as I mentioned during my introductory comments with Dr. Shah, you know, it's critical that we really have an understanding and experience, not just understanding, but experience with conventional freehand full arch immediate reconstruction surgery before attempting fully guided. And I say this with all due respect because there are cases where we can't do a conversion, a fully guided case to completion for a number of reasons. And therefore, one has to shift gears and go to brain-guided surgery. And this is important to be able to appreciate. So just a word of caution. Now, what is this protocol about? Just quickly, I will tell you that it involves a fully digitally planned guided surgical approach. Where using the in-sequence guided prosthetic protocol, we are literally preparing everything in the virtual world and then being able to have application from the lab perspective and then obviously to the clinical. So there's proof of concept throughout, as we'll talk about in a bit. And digital records are important, of course. There are 5 recorded items that are needed. Photos should go without saying in this day and age, of course. These STL files are submitted to the lab in Reno, Nevada, where in-sequence is located. Our bite registration is then done typically with Blue Moose. Can also utilize our intraoral scanners, but for sake of this protocol, the bite registration, physical registration is very important to have. And then we scan our patient with that registration in place. And of course, those DICOM files are sent to the lab as well. And finally, a digital dental lab slip is completed. Now, that said, this digital 3D data set is then merged with the underlying 3D bone structure so that a complete 3D patient-specific data set is then created on the lab end. And this then allows us to come together for a true interdisciplinary team web meeting, meaning between the surgical-based individual, the restorative-based individual, and of course, the laboratory individual in Reno. And it's during that time that we are looking at a number of facially driven treatment principles, as you see here, which ultimately are all virtually implemented. And that's the key here, so that we're able to go through our case in detail in the virtual world once again. And as you see here, ostectomies are created very specifically, very precision based, and implant placement then is predicated on the actual occlusal, or I should say tooth setup, that's of course done virtually, like a virtual wax up. And beginning with the end in mind really happens at this point, meaning very critically, we're looking at implant length, diameter, angulation, etc., and fitting, of course, within the realm of the prosthesis. And once that is done, then there's a milling and rapid prototyping of the prosthesis that occurs. And ultimately, as you see here, there's laboratory validation done via dry model surgery. And this is very labor intensive. And again, I give all the credit to the in-sequence folks who are able to, do this in such a predictable mode that what that translates into is a set of models, surgical guides, and of course the prosthesis itself that is then packaged and sent to us. And in advance of the surgery, we're able to simulate the entire protocol from A to Z. And it's just a wonderful way to utilize such a predictable system. And then, of course, the prosthesis is delivered at day of surgery, so that not just the surgery that is guided, but certainly the prosthesis, and that's made in advance, as we just discussed. So that day of surgery, the patient will leave with teeth in place. And these, again, are not conversion dentures. They are beautifully done FP3 type prostheses that are fabricated quite nicely in advance of our surgery. So just a couple quick cases to share with you that will kind of put things together with regard to that protocol. This is Virgie. Virgie's in her early 70s at the time. And as you can see, presents with some issues in terms of existing dentition. She has an occlusal cant, certainly, as we can see better in this close-up. And some issues with regard to maxillary dentition. The mandibular arch, very stable, periodontally, the periodontium rather is stable, and conventional restorative dentistry can be done there, which was done ultimately with, I believe, 1 or 2 implants in addition. But it was the maxillary arch that we're addressing. And again, with these types of cases, we look at them very critically and always give our patients options. Option 1 being maintaining what they have, with selective extractions and perhaps implant placement for fixed work, or even removable appliances. And then certainly one option, and in many cases is the most logical one, and that would be full arch edentulation with immediate implant placement and teeth as well. So our virtual treatment planning here for Virgie, as you see, the ostectomy is created here virtually, ideal tooth setup and implant placement, where you can see we're able to guide this nicely at our go-to meeting. And this is probably the most important slide that depicts what goes on in these sagittal sections, meaning we literally will place these implants where they need to be, both again in the vertical dimension, certainly AP, etc. Another a true 3D placement of the implants, length, diameter, angulation. All of this is done virtually, and then of course transferred to a set of surgical guides. So time of surgery, as you're seeing here, a bone foundation guide is created that's placed over the arch where teeth have been extracted already. And these particular struts are, I would say, a 2.0 iteration of the existing system. It is now in its third generation of strut formation. But in a nutshell, this foundation guide serves as a true foundation for every guide that will follow, because it is a stacked system and one that is extremely accurate. In fact, so accurate that I would say that what few errors we've had over the years have been on my end, meaning human-based, such that as a result, the case can be accurately inaccurate from that point forward based on human error, not so much from the lab perspective, that's for sure. But to show proof of concept, this is the foundation guide in place, and that's the amount of bone that needs to be reduced and removed to allow for good restorative space that's needed in so many of our cases. And this is nothing more than a indication, or I should say a duplication of the bone segment from the model that we will have had in advance to show that this equals this quite nicely. And then of course, a designated guided surgical kit is important. The one I use the most for this protocol is the Bi-Horizon one. And the implant design must be important. It must be, I should say, aggressive in order to allow for good primary insertion torques, good primary stability, I should say, and good high insertion torques. And this thread design is a great one, and been using this now for a number of years. So we have different ways of improving primary stability. As you can see here, most all the time we're under preparing our osteotomy, and depending on the implant type and length of the implant, these dictate, of course, the success rate of our insertion torques. And last but not least, in the last 5 years or so, osteodensification has entered into the picture. This played a huge role for my full arch cases, non-guided. So here we're seeing just a sequence of events where the implants have been placed via, again, fully guided approach. Our multi-abutments are in place, our copings, and then finally a gasket with pickup of the prosthesis, as you're seeing here, with a dual cure flowable composite. And we're able to very nicely pick up the prosthesis predictably. And again, here is where it's important that we look at grafting our defects. As I mentioned in my earlier comments, from both a hard and soft tissue perspective, we cannot ignore this. It's very important to the long-term stability and success and predictability of our cases. So what goes on now over the approximately 25 to 30 minutes of time is a refinement of the prosthesis. It's not a conversion. We're not taking a denture prosthesis and converting it and having innate maintenance issues, etc. This is a beautifully designed PMMA prosthesis that is literally refined by a chairside assistant is really all we need. We don't need a full-blown lab technician at all for these cases. And while this is going on, I'm closing the case, I'm grafting and getting soft tissue closure, of course, of the arch, in this case, the maxilla. So here you see the completed bridge in place. And of course, this will be secured and functional for 4 months. Patients on soft diet, as we know, allowing these implants to integrate nicely with the patient's existing bone. Here, just a little video of the case from start to finish. We'll give you an overview of what does go on here. Edentulation, of course, to begin with. And it's important that we be super careful in removing these teeth. We don't want to expand our alveolar ridge because that foundation guide then would not necessarily fit so well. So it's important that we be very conservative with extractions in general, which should be true all the time. This is the foundation guide in place with these so-called monostruts. They are now fused as one, and they're literally termed a monostrut versus these 3 separate ones. Here you're seeing these struts removed. We've keyed our foundation guide and then pinned it, drilled holes and pinned it. Now we're reducing the bone, as you see here. And once that bone reduction has occurred, we can place a surgical guide directly onto the foundation guide. And what this allows now is a true guided approach with, of course, the keys of whatever implant system you're working with, so that sequentially we can create the osteotomies needed. And then, of course, the implants are placed accordingly, all pre-planned, mind you. So the day of surgery, really, it's just like more or less well, we've worked as a flight simulator kind of concept in advance. So our brain understands that we've already done the surgery. So it's like a flight list, really, that we've got 17, 18 steps, for example, 1 to 2 to 3 to 4 in order, so that we can perform this surgery so predictably. You see the implants are in place. We've reduced bone around them. Now the multi-abutments have been pre-selected in advance and they're keyed, so there's no guesswork. We know exactly where each of these particular multi-abutments are going to be positioned. Again, pre-planned, and we have small handles so that, as you see here, with each placement of the multi-abutment in the handle, we can then make sure that we have good clearance with the actual prosthesis, that we have good draw. And we do this with each multi-abutment that's placed, one by one. And once that's done, we'll place the copings, and therefore we know in advance that we're good to go. These copings, of course, are non-engaging. They have 2 flat sides, and typically one will be placed to the facial. They've been pre-selected, once again, and numbered so that we know exactly where they're going. And in fact, each implant site has a small box of little parts and pieces that need to be utilized just per that site. And here you're seeing the actual teeth in place. We will have placed our guide into position so that we're occluding well and making sure that these teeth are in the correct position. Now, the third iteration of this particular protocol, we don't need the mandible, for example, to be auto-rotated into position. We don't even need a bite guide. We can do this with the mouth open. And in fact, the entire protocol has been modified such that it really is allows for a less invasive surgical approach to our maxillary cases in particular. Here we're reducing, I should say, contouring our bone. Any sharp bone areas are rounded. We're grafting extraction sites, placing PRF membranes for enhancing angiogenesis only for our cases. And then, of course, healing abutments are placed and we get primary closure. While all this is happening, the prosthesis is being refined, as I mentioned earlier. And that's a good thing, because basically within 25 to 30 minutes, we have this completely finished and now ready for placement. And of course, screw retention is the name of the game here. And once we've done that, we'll have placed our plumber's tape and sealed off our small openings within the screw access areas. And of course, we can cure those sites, and we're all done with our surgery. And of course, as you see here, in summary, we started with these existing teeth. We have extracted them in a very conservative mode, placed our bone foundation guide, placed our surgical guide with implants, our multi abutments, our copings, the prosthesis itself. And once that is removed, we will have grafted and placed the provisional prosthesis. And we have a nice, happy patient, as is true all the time. So, in a nutshell, I've shared with you that protocol with video to better appreciate what we can do. Here's a 1 month follow-up at 4 weeks. By the way, I do use resorbable sutures, 40 chromic, so don't have to really be worried about removing these sutures. They'll come out on their own for the most part. And there's a follow-up scan, screen capture. And here's Virgie at 6 years. And most importantly, and we're using, by the way, in this case, we used a zirconium prosthesis. I'm a big fan of a nano ceramic that we've been working with now for about 3.5 years, and working with a few other hybrid types that we like, because from a maintenance standpoint, if there is an issue, we can repair that rather easily versus a full zirconia prosthesis, as you can imagine, with a chip that has to be completely redone. And this is the most important slide, I think, in any case presentation of this type, where in sagittal section, we can appreciate, even at 6 years, what things look like from a bone implant perspective, meaning that facial plate has been maintained well. And that, again, plays off of our grafting techniques. So really, although as most of you would know, or if you know me at all, I've been known for bone grafting all these years. That hasn't gone away. Don't graft as much as I did in the past with a number of our cases, depending on the minimally invasive techniques and protocols that I've been following and using. But in conjunction with our full arch cases, once again, we're not getting rid of bone grafting at all. In fact, on the contrary, once again, I think it's critical that we graft extraction sites, extraction defects, and in some cases, even some sinuses and even subnasal grafting. So that is important for long-term success, in addition, of course, to our soft tissue concerns that I've mentioned already. And just quickly, a second and final case to share with you, an edentulous patient. Ed came to us very upset, very depressed, not wearing dentures, fully edentulous in both arches, but just didn't care to wear his teeth because he was unhappy with how he looked, and the fact that they weren't exactly fitting so well, et cetera, et cetera. So cases like this, we will fabricate a full set of teeth, in this case, a full upper and full lower denture with these fiduciary markers, as you see. And then, of course, use a dual scan technique where we're scanning the prosthesis outside of the mouth and then, of course, inside the mouth. And of course, our CBCT workup is invaluable with all of these cases. Here we have good division A bone present in both maxilla and mandible. So I thought, well, why not look at this as a flapless guided surgical protocol? Why not use that? And I'll be honest and very transparent about placing implants flapless. I'm not a big fan. This is one of 2 cases I could share with you in all these years that I did this way, more or less to say I did one, and I can share it with you. But honestly, I like to fully expose, in other words, full flap reflect, even an edentulous maxilla or mandible, to see exactly what I'm dealing with, especially from a density of bone standpoint. So a number of reasons point to not doing flapless surgery. But that said, here we are. And the workup involves a diagnostic denture conversion. In other words, from a virtual perspective, what I'm saying here is the teeth that were fabricated were then digitized. And here you see the dentures in place and occlusion. And of course, this is the optimal setup that N-Sequence will do for all of our cases. And this setup is done in advance of that virtual meeting, at which time we can direct traffic, meaning specifically where the implants need to be placed in 3 dimensions. Again, in terms of length and diameter of the implants, angulation, et cetera. All of that is done, again, virtually, as you're seeing right here. So decided to go with just 4 implants. In hindsight, a fellow this size, although he's held up well for 9 years already, I would probably place 5. I'm a big fan of looking at a number of parameters, as most everybody is, certainly, meaning if we have any element of, for example, bruxism, any parafunctional issues like that, our male patients in general have stronger bites than our female population. Age becomes a factor. There's so many factors that, of course, we look at for treatment planning in general. But here for Ed, decided let's just do 4. He's got great bone, and we planned accordingly, as you're seeing here in these sagittal sections. Now, the negative, if you will, of doing a flapless case for fully edentulous maxilla and mandible is as follows, and that is these guys are soft tissue borne. And as we know, versus say bone and tooth supported, this type of guide lends itself to some error. So we have to keep that in mind if we're even thinking about guiding these cases flapless. But at any rate, what I'm sharing with you is how we did this, meaning, as you can see, there are guides built in place for both arches with a bite, and that needs to be established right off the bat so that we can literally fixate both of these guides and then remove, what I did here is remove the mandibular guide and then address the maxilla to start. And of course, after trephinating our tissue core out, we can then go through a sequence of keys with appropriate drill sequence to create the osteotomies necessary for implant placement. As you're seeing here, the prosthesis has been picked up, and we address then the mandibular arch in the same way. And you can see by these markings that really minimal time is needed. I mean, minimal time to adjust occlusion. And in fact, in Virgie's case, I didn't mention that without pictures, without photography, without video, that kind of a single arch case can be done in 2 hours. It's not really that difficult. A dual arch case can be done in 4.5 hours maximum. And a case like this, where you're seeing a complete upper and lower flapless situation, can be done very fast, like within an hour. Again, there's no race for anybody. I'm just saying that once you're up and running, how many cases are needed, how many arches should be done to really feel comfortable with your team? I'm going to say 8 to 10 on average, because at first it will be overwhelming, all the parts and pieces and things that need to be spread out on your bench area and tabletops can be overwhelming to begin with. But I will tell you that once, like anything else, repetition will allow you to become more comfortable with the protocol, your team as well, and then everything gets set up nicely in advance of the surgery. You don't want to be opening up this box of goodies the night before or the morning of surgery. Certainly you'll receive it about a week in advance, and it's during that time that you and your team will go over everything from A to Z and be able to appreciate the protocol and the sequential steps involved to giving you a very predictable result, be it single arch rather, or dual arch. I strongly recommend avoiding dual arch cases for at least 8 to 10 times. I would say those first cases should be single arch, definitely, and then wean slowly to dual arch. But once you are understanding the protocol, it really de-stresses one quite well. You and your team, I promise you. So again, cross sections of the specific implant sites, as you're seeing here. Here's a 9-year follow-up. Again, for dual arch, at least at that time frame, we used zirconia upper and acrylic wrap on the bottom, allowing for any type of wear to be done in the lower arch and could be addressed accordingly. Zirconia, opposing zirconia, the noise effect alone can be just not, well, let's put it this way, very problematic. Never liked that idea, that concept. And for a number of reasons, again, we're liking more the nano ceramic for both arches for that matter. And again, a 9-year follow-up, as we're seeing here for Ed, looks quite predictable. Yes, and it is. The protocol is such that, as you're seeing, we had division A bone and 9-year follow-ups. Really, there's no bone loss to speak of. Can there be implant failures? Absolutely, yes. And in fact, If a distal implant were to fail, or I should say, let's say we don't even get good insertion torque, then we have a couple options, one being cut the prosthesis and minimize a cantilever. And if we have more than one implant that's in these guided cases that we don't have a good insertion torque, meaning at a minimum, let's say 30, 35 Newton centimeters, then we could elect to, if one is not comfortable with zygomatic implants, then the only bailout would be a full upper denture. And the patient would have to certainly be made aware of that in advance of surgery. But I will say this, that if one is careful in selecting patients that have good bone in zones 1 and 2, and that's the Bedrosian classification that we all have looked at and I think follow for the most part, meaning zone 1 being the premaxilla, cuspid to cuspid, the anterior dentition more or less, zone 2 being the bicuspids, first and second, zone 3 the molars, and then zone 4 more or less can be called really or applied to the zygomatic bone bilaterally. So zones 1 and 2 again, meaning canine to canine, and then second bicuspid, including second and first bicuspid teeth bilaterally. If we have bone in zones 1 and 2, those cases lend themselves to fully guided protocols, as we're sharing with you here with the unsequenced protocol. Once we have no bone in zone 2, then we're off to typically at least a hybrid zygomatic case, meaning single zygomas, one on each side. If there's not bone in any of the zones, well, then so-called no zone bone, those are quad zygoma patients that we work on. So we're literally placing 4 zygomatic implants. So at the end of the day, it really boils down to quality of life. As we know, these cases are so, I would say, fulfilling for our patients, certainly, but also for us as clinicians, no doubt, and our staff. We all get excited when we are able to have our patient there and we're placing these teeth and then showing them the mirror, and they're seeing themselves for the first time with a new start, more or less. The third dentition, as we call it. Mark Adams coined that term, at least I think he did, and I first saw him years back, and I remember him, that was the title of his whole talk, is the third dentition. Now, God gave us deciduous teeth, permanent teeth, and now we've got even a third shot at having good, beautiful, permanent teeth. And as a result, our patients certainly benefit immensely, improve self-images. We're transforming their lives, literally. Self-image changes really occur in so different, many ways. We see them outwardly represented by a change of clothes, hairdos, cosmetics with our female patients in particular, et cetera, et cetera. But it's just so fulfilling for us to see these patients light up like a light bulb, and they just see themselves differently. And as a result, they have a new lease on life, so to speak. And it's just very rewarding for all of us, certainly involved. So we're transforming lives, no doubt about it. And as we know, even a single tooth replacement can change a person's life, no doubt about it, let alone full arch and certainly full mouth reconstruction cases like these. And as I mentioned, they are challenging, and they absolutely play on all of our more or less clinical experiences and skill sets, meaning we still need to incorporate some bone grafting, some soft tissue grafting, and of course, precision implant placement. And with this guided protocol, I will tell you that in summary, if we're comparing the fully guided full arch immediate in sequence prosthetic protocol to a denture conversion or 2D freehand, there are at least 7 advantages as I see it. So number 1, the precision planning, as you saw, and the virtual workup is just extremely spot on versus our conventional 2D planning for an immediate denture and the conversion approach. I don't think there's any comparison here whatsoever. And from a true collaborative accountability perspective, meaning we're truly planning this from an interdisciplinary treatment planning perspective. Again, we have a restorative individual, our surgical-based person, and our lab individual. And in the cases where the restorative and surgical individual are one and the same, then it's even more straightforward. That individual then interfaces directly with the lab. Versus in a denture conversion protocol, we have I would say, I hate to use the term, but for lack of a better, a suboptimal interdisciplinary treatment planning approach, because in many of the cases, it's basically two-dimensional, flat, panoramic view, screen capture of a CBCT, but more looking at the two-dimensional element than the third dimension. And of course, fewer patient appointments with this fully guided approach, meaning as many, or as few, I should say, as 4 to 5 ultimately, because think about it, there's a digital file for this particular patient, meaning upper and or lower arch. So in going from a provisional permanent set of teeth to the final permanent set of teeth, only alterations that need to be made can be done virtually, of course, like a kind of digital wax up, if you will. So the 2 appointments are all that's necessary, meaning an appointment initially to address the soft tissue changes that will occur over the 4 months of healing time, and the patient again being on a soft diet. That can be picked up certainly in that 1 appointment, and then appointment 2, the final prosthesis is then seated. Less chair time by far, no question about it. Once again, this protocol is mastered. One can just go buzz right through a 2-arch case in 4 hours or less, just depending on the number of teeth involved and how ankylosed they may be. That's really a rate limiting step, to be quite honest. So less chair time in general, which means less anesthesia time and less morbidity overall to the patient. The material is much stronger. A reinforced PMMA provisional, I have listed here titanium reinforced, but now today the provisional really is a very strong PMMA prosthesis that has no metal to start, and therefore maintains itself quite well. And in fact, the last 3.5, 4 years, we've had 0 maintenance issues using this protocol. So that's really an important point to consider versus the non-reinforced conventional immediate horseshoe denture. And of course, it's very predictable, patient-specific, and affordable. And that is important because we're always looking out for the best of our patients, meaning the least invasive procedures we can do, the fewer number of procedures we can do, certainly, and of course, keeping costs contained as best as we can for our patients. So versus a less predictable, less patient-specific approach with our denture conversion. And last but not least, I think you'll agree that from a pure documentation standpoint, medical legal, if you will, there's nothing in my humble opinion that really gives us so much information, so much data that from a comprehensive looking at this protocol from A to Z, there's just so much there that documents everything we have done from A to Z versus, again, I'll use the term suboptimal documentation, no disrespect to the denture conversion protocol. It's just that when we have the ability to guide our cases, not just surgical, but again, from a restorative perspective, then, why not? I mean, you can see these advantages on the right-hand side from 1 to 7. So at the end of the day, we have reactive versus proactive. I think there's something to be said for that proactive approach, as I've attempted to share with you in this time together here for this mini presentation, just kind of give you a quick overview of the detail that's involved. Quite honestly, our course is 3 full days, and talk about less stress. My goodness, that's probably the bottom line for all of us, because that day of surgery is really a very relaxed one because you've already done everything in advance. If you think about it, again, like a flight simulator, the brain cannot comprehend virtual versus reality. And that's a good thing, because if you've gone through all of these steps, and you should with your team, we typically use Panadent articulators. We have the models sent to us from the lab that are all printed models of the existing maxilla and mandible, and you're able to utilize the different guides because everything is more or less made in such a way that we can remove teeth as one piece, and the bone segment can then be placed onto the models, etc. So in a nutshell, we can simulate the entire surgery, and we should do that with your team at least your first few times together. And then on your own, just looking at the models, etc. So then a day of surgery, your brain is believing that you did this already. So you're really just smoothly going through these steps. And it's like a flight plan, really 16, 17, 15 steps, pick a number. We're just following the order, and the predictability is just so good. So this is our next course. As Kianor had mentioned, it's January 13th to the 15th. We've got, I think, 4 or 5 spots left. Whoever has interest, certainly feel free to find us at Picos Implant Institute.com, and we'll be happy to accommodate you. We've got about a month out, and we typically will be at full capacity with all of our courses here in due time. And just a few comments regarding a true joy of my life here as I've gotten older now and being able to have a different dynamic, and that is with grandchildren. And our daughter Lindsay has these 2 children, our granddaughter and grandson. This is Ella Sophia, she's 3.5. And this is Andy, little Andy man, as we call him, Andrew Samuel. And they're just a joy to be with. And my wife here, Diane, is our nurse anesthetist. She's a member of our team. Certainly plays a very huge role with our full arch cases because she does the deep sedation for our cases. But the grandkids, I'll tell you, a great dynamic. Those of you that are grandparents know exactly what I'm talking about. Last night was a little Christmas play that little Ella Sophia was involved in, and boy, I tell you, nothing more than exciting than being a proud grandparent and being right up front, just as I did with my kids. And except having a video camera, I've got my little phone, much easier, much less involved, of course, to carry, but the excitement is just so neat. So that's been a true joy for me. So with all that said, I want to thank all of you for your attention, and Kianor in particular, I thank you for again the opportunity to be able to share some of my clinical work with my colleagues from throughout the world. And I applaud you for what you've accomplished, in particular with this organization, an amazing one. I don't know how you find the time and effort to do all the things that you do. You are amazing. So with that said, again, I thank all of you, and look forward to some closing comments and questions that will be answered. Yes.
Wow, that was quite a lecture. I was listening very, very closely. Thank you, Dr. Pikos, for presenting these 2 wonderful cases. And knowing you and your family, maybe there's a chance that Ella and Sophia may also become dental professionals. I understand your son and daughter are in the dental industry, and hopefully we can continue learning from them in the ages to come. Couple of questions for you, Doc. You showed 2 beautiful cases. You covered a lot of things actually in those cases that I was paying attention to, which was also the tooth-borne and tissue-borne guide scenarios. The tooth-borne scenario made a very strong point that if the preparation is done properly, it's pretty much virtually defect-free. It's very accurate. You don't have to worry about that. What is your process on compensating for inaccuracies in the edentulous scenarios, in the second scenario, when you're doing it guided? I understand you don't like doing anything flapless. How do you accommodate for that, for someone that's scared to punch into a nerve or what have you, trying to do these full guides on an edentulous patient?
Well, again, I think it's very important that one has experience with brain-guided surgery, meaning full flap reflection. Let's take a mandible. You know, over the years, so many cases that I can look back upon that I learned so much from, that allowed me to morph into the fixed work, certainly. But in a nutshell, knowing the anatomy well, our CBCT scans are very, very accurate, certainly, and has given us so much of an advantage. I would say I embraced this technology in 2005, so it's about 16 years that we've had cone beam units in all of our offices. And without that, I would be crippled at this point to even think about teaching, let alone doing any real surgery, knowing what I know today with our cone beam CT technology, certainly, and as you well know too. So important that one start slow, meaning a full arch, I should say an edentulous arch that would allow one to place, say, 2 implants for tissue-borne overdenture would be a good start. And appreciating the anatomy so that you can stay certainly away from the mental neurovascular bundles, for example, and therefore not have any problems with the nerve itself and sensory loss, etc. So starting that way, I think is important. And then from that, of course, surgical principles that need to be followed will be applied to our fixed work down the road. But that straightforward type of division A mandible would be a very good start, I would say. And then go from there. As far as guiding, once again, I would not recommend a flapless approach, even with all the experience I have. I still like to see that bone. And if I'm having to reduce bone, of course, you have to flap it anyway. But even if you didn't, I would say it's important to fully reflect your flaps and see firsthand where the bundles are, for example, in the mandible and the maxilla. Of course, you have your different landmarks to appreciate, et cetera, et cetera. But again, I can't emphasize the importance of knowing how to do brain-guided surgery first and foremost before fully guided. And that's not just for full arch, but even for partially edentulous spans. I think those individuals that are really stressing so much using guides, and to the point where, don't even worry about freehanding anything, taking folks that are very entry level and saying, okay, here's the guide, just, drill the holes, etc. You can flap, but, just put this in place and go. Not a good idea. And for a number of reasons, not the least of which is you need to know how to bail out of a problem with guided surgery, and they will occur, whether it's lack of insertion, primary stability to start of your implant, and or bone that you thought was there that isn't. So many things can happen that you discover intraoperatively, and you just have to know what to do then. And that what to do is the guide's gone, throw it away, and now you're freehanding. So I think the best analogy I can use is the lateral wall sinus graft versus the crestal sinus graft. And I like that analogy a lot because it just, I think, brings things in perspective. Meaning, up until roughly 5 years ago, I performed and taught basically only lateral wall sinus grafting. Done over 1,400 of these cases over the years since '89, and still feel extremely comfortable, not an issue to do them. However, just because of one technology, and that being osteodensification, that kind of opened up my eyes and allowed me to look at a crestal approach now in a very different way, because prior to these last 5.5 or so years, all of the cases, or all the protocols that I've been aware of and even played with some of them in terms of using the crestal approach, none of them really predictable. All of them were blind approaches to that, to the membrane itself, to the sinus. So therefore, a perforation could occur, wouldn't even know it happened. Let's say you place some graft material. Now it's like, shrapnel all through the sinus, a little too late. Now what do? Close up and abort? Well, have a problem. We've got the graft all over the sinus. However, if you know how to perform a lateral wall graft, then obviously you create your lateral window and you go about your business. So that's just one easy example, but a big one. And so therefore, what I'm saying is that you get a large perforation, et cetera, you have to know how to shift gears and go to your lateral approach. Now, with that said, with osteodensification, it allowed me the opportunity to really hone in on this nicely, as I know many, many folks have embraced this throughout the world. And we're able to then look at these cases differently, so that I would say now the number of lateral wall cases I do is less than before, meaning up until 5 years ago or so, yes, but not completely wiped out. Now, that's where I have an issue with those folks that are running around the world saying, hey, look, especially for the novice, the entry-level clinician, don't worry about you learning how to do lateral wall cases. You don't ever have to, quote unquote, do those. I cringe when I hear that, because there's at least 5 reasons. I don't have time to get into all the details, but there's 5 bona fide reasons, one of which I mentioned, a perforation during crestal, and you've already introduced graft material. Now what do? Okay, and how about a fully pneumatized sinus? Fully pneumatized, which is going to be in our edentulous patient population. And if you are going to graft for whatever reasons, those cases, there is no way there's predictability to go from 0 to 8 or 10. We see cases of an N of maybe 1, 3, 5, but show me 10 consecutive, and I might buy into the protocol. So again, not to throw stones at anybody in particular. It's just that I have a real problem with folks being all or none. That quite honestly, you need to know how to do lateral wall before you even think about doing crestal. And just to take that a step further, okay, let's say you and I have an appendicitis attack right now. We're rushed to the hospital. All right. Odds are you're going to wake up from your surgery, right, with 8 or 10 little dots in your belly. Of course. You know why? You were scoped and no big deal, blah, 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 minimally invasive. But maybe I wake up and I see an incision. What happened? What happened? Well, what happened is my surgeon probably encountered a bad bleed, couldn't get good access, and he or she had to open me up and grab the bleed, take care of it, blah, blah, blah. In other words, if my surgeon, which of course would never be true, but didn't know how to do the invasive approach for me, I'm going to probably die. Now, you're not going to die from a sinus graft necessarily, although you could with a bad infection. But my point is, you need to know how to do the invasive approach first before you think about the minimally invasive. You need to know how to do brain guided surgery before you approach guided surgery. Those are my strong comments. And I can tell you that over the years, time has shown that those statements are very, very true. And I just have a real problem once again of the big push of, again, I'm a big osteodensification guy. Absolutely, yes. Probably the biggest one in this country, hands down. I've taught it in all of my courses these past 5 years, et cetera, et cetera. I walk the talk. I use those drills, by the way, those births for every case I do non-guided.
Versa drills, you're using them?
Versa, because again, they're not only used in a counterclockwise mode, but also in a clockwise mode for D1 and D2 bones. So I use them every day. So I walk the talk with those drills, but the protocols I think are being pushed by some individuals a little bit too much. And the statements are very bold to say, once again, don't worry about doing a lateral wall approach. I think that's a real problem. And not to mention that you have pathology. Now imagine a large mucus retention cyst, and I've got a number of those cases to share. Certainly go over them in my courses, but I share them online with some open webinars where literally I've removed them. They've occupied the entire sinus. Picture that. The entire sinus is opacified. Are you going to suck that rascal out through a crestal approach? I mean, really? I don't think so. You've got to open it up, remove it. And then what do you do when you remove it? Because the membrane is gone now too. So you're staring at the infraorbital floor and the medial wall of the sinus, et cetera. Do you abort? No. I can tell you in all my years of sinus grafting, I have not aborted one case, not one lateral wall case, because of the protocol I came up with years ago with fixating a large collagen membrane, 30 by 40, in some cases even splicing 2 of those to accommodate and recreate the new sealing of the sinus with external fixation, sometimes internal fixation. My point is, don't need to abort the case. But my real point is that case cannot be done via a crestal approach. Impossible. And I've got 5 reasons altogether of why lateral wall must still be taught and must still be learned before one even thinks about a crestal approach. And that's how I continue to teach here at the Institute. So I don't want to carry on that topic in particular, but because of the way it kind of all evolved here, I think it's important with the analogies that I drive that point home. And once again, back to my guided topic here, one needs to know how to do brain guided surgery first and foremost, feel comfortable, because the principles that we do for brain guided, honestly, apply directly to the guided. And if you get into trouble with a guided, you throw that guide away and you go freehand. And to take it a step further in the maxilla, if you're comfortable with zygomatic implants, well, then guess what happens? All of a sudden, maybe that case became a single or double zygoma case. And if it is, it is. Pterygoids, whatever you need to do, learn the protocols, be comfortable, and then incorporate them like anything else we do. Nothing is magic. I'm convinced all of us can do what we're showing. It just takes practice and mentorship, etc. And that's the beauty of what we do for all of us globally. And again, I applaud you for what you've done. You've really embraced and brought everybody together in such a nice way globally that we are all really one family. So online, that is a big advantage of social media because we can share things like now among ourselves and we learn from each other. Absolutely. We learn from our own problems, but we also, it's better to learn from someone else's problems, right? And complications all the time. Absolutely. Yes.
That was great. You raised a lot of debates and discussed your position on them, and I really appreciate it. That was good. So you need to be able to use your brain. Just you cannot 100% just rely on something sent to you and start drilling. You got to understand a lot more. And yes, you answered my subsequent question. If something goes bad during the surgery, you got to put the guide aside and go freehand and finish it up. You can't just abort. You got a really bad situation on your hand. So on those two cases that you showed, Doc, and one of them, in the first one, you placed 5 implants with 1 central on the upper, which I thought was pretty cool. And on the other, you did the conventional Allon 4. In your scenario, it's the Allon X, Y, Z. When you place them, when you decide you spread, and they both had an excellent spread, at what point do you place them in the center, and what do you do with the greater palatine? Do you clean it out, or what is your protocol?
Great question. Great question. That comes up time to time. And I think a misnomer among some clinicians is that that's such a sacred place to stay away from, meaning the greater palatine, sides of canal area.
I've never had a problem, yeah.
Yeah, exactly. And when I was doing the Ford osteotomy, down fracture of the maxilla, we severed that all the time. Was there ever an issue? Once in a blue moon, a patient would come back and say, you know, doc, I feel a little numbness in the roof of my mouth. And I look at them, I go, oh, well, you know, okay. What if I cut your arm off? Just curious, would that, you think that would be bad? Like, and they look at me like, is he goofy, or, you know, what's going through his head? And it's, you know, it's all relative, right? And weeks later, they don't even know anything happened. That's about the worst situation, meaning some sensory loss. Not a big deal.
Any implant failure, any infection around the implant because of that nerve?
Not that I can think of offhand, honestly, because I routinely will clean that out, meaning I basically sever that neurovascular bundle. I then cauterize it and I remove it with an 8-round burr and literally burnish that canal till I get good bleeding bone. And I'm either grafting that site or placing an implant, depending on the specific anatomy of that arch. Yes, but I have no problem. In fact, it's great to place an implant into that particular foramen. Again, understanding and appreciating the anatomy, knowing where that nasal floor is, to not violate it. I mean, you can certainly have an implant go up a millimeter or so into the base of the nose, not an issue there, but beyond that, it can be problematic. You don't want to tear your membrane, of course, etc. But that's all, you know, taken care of from our scan in advance of the surgery, etc. But it's fair game to literally remove the contents and place an implant and or graft it. We have our European colleagues that have literally, you know, looked at this and gone, okay, we can lateralize the bundle and still graft and maintain vascularity, you know, of the flap. Honestly, I think that's okay to do, but I've never done it. I don't think it's necessary. It's all or none. You either leave it alone, or if it's in the way, which most of the time it is, then I literally eliminate it and graft and or place the implant accordingly. Within the
same note, do you do it down here as well on the lowers? Have you ever done that?
I'm sorry?
In the center? Have you placed it in the center before in the lowers as well?
Dead center, yes. Depending on the anatomy of the patient, the arch form, sure, I certainly have.
That leads me to the next question right there, Doc.
Staying within the prosthetic envelope.
So on the first case, you had 5 of them, and then you explained that if one of them, say, fails because for whatever reason, patient compliance, what have you, you have Allon 4 on top, one of them fails. I kind of want to know what your protocol is. If you have 5 on top, which to the center one, and let's say one distal one's fell, you have a pretty strong AP spread still. So you have 2 and 2, one goes. how much of a headache are you looking at? Because I'm not sure if you cut that one off, if you cut the prosthetic off, if that's going to solve the whole problem.
Well, no, it would depend, on the specifics of the case. So let's say the case of 5, you've got one more or less either center or just off center in the 8-9 site. You've got one each in the canine and then one back in the second bi or even molar areas. If a distal, let's say case situation 1, the midline implant failed, or even one of your paramidline, that prosthesis probably will still function fine regardless. That cantilever is built in, it's internal, it's not so bad. If a distal implant would fail, that's the issue. Then of course you got that distal long cantilever that would need to be addressed with either removing, or I should say sectioning that prosthesis, maybe one tooth more, etc., or perhaps you can then use a pterygoid implant or a zygomatic implant as a rescue implant, and then create a new prosthesis, I should say, ultimately. Yes.
So now it's a lot harder to go to end sequence the digital route versus trying to do that freehand, because you got to put all
correct. Yeah, it's all different
on, and much easier since you have all the scans, and they can make a prosthetic a lot faster than starting again with Duralay and all of the flaws.
Well, quite honestly, we've used photogrammetry for about 3.5 years, so we really don't have to worry about models and occlusal rims, etc. All that is out the window, because again, photogrammetry being so 10 micron precision, just gorgeous. I mean, Adrian Hernandez really had come up with an amazing technology for us all that has changed. Well, it's radically changed our workflow on the restorative end to be completely digital. Only a couple intraoperative alginists are taken. That's about it for tissue, for soft tissue drape verification. And then even those impressions are box scanned, and that's digitized and sent to the lab. So it's basically all digital. So we can pick up any implant, of course, whether be the zygomas, pterygoids, vomer, it doesn't really matter. All that matters is what's in the mouth, of course. But the beauty of technology, again, it continues to increase at such a great rate that I'm envious of all of the young folks out there that, including yourself, who have so many years ahead of you. I mean, God willing, it's a great thing, because the technology is going to continue to get better and better for us and improve our patients' lives indirectly and make our lives better, because we can then utilize the technology in such a neat way that it makes a difference for us in terms of our approaches, our time invested with our patients, etc. But most importantly, the predictability is going to get even better. There's so many neat things coming down the pike. I've been involved with a dental cement, if you will, for several years, about 5 years, and this will be another very, I'll call it a huge game changer for us all, because imagine an adhesive, for example, that will allow us to bond an implant to bone immediately and not have to worry about insertion torques. I mean, that's a whole nother ball game that's coming down the pike. So a lot to be said for that. But again, there's so much out there that I think it's important that we continue to share among ourselves what we learn, and therefore make literally our patients' lives that much better, and in such a faster way. And that's what it's all about, is time and predictability. It's just going to get better and better.
Looking forward to that. Doc, I'm going to ask you one last question. I know it's clinic hours, and I'm not trying to take up too much of your time here. We appreciate what you have invested already. When is the red line for you where you say, hey, there's no point in grafting this case, let's go to zygomas?
Well, that's a pretty easy decision, quite honestly, because, I would say that I have not.
Even if you had some bone in the front for an Allon 4 or something like that. I mean, tilted implants.
Well, again, it depends where that bone is. Again, zones 1 and 2, we don't need to place zygomatic implants. And in fact, the rule of thumb is where you don't need to place them, you don't want to place them. You don't, because they do have issues with them. In fact, because of that, it took me quite some time to really get involved with zygomatic implants, because I saw morbidity and read the literature, etc. But what's happened over the years now, and I give a lot of credit to our European colleagues, in particular Carlos Aparicio, for his Zaga concept, which I have embraced completely, and is a very nice prophylactic approach to zygomatic implant therapy. And in a nutshell, involves bone and soft tissue, believe it or not. And there's the XYZ, again, concept of specific implant placement and even design of the zygomatic implants. But most importantly is an osteotomy that's created in such a way that it's very conservative and is, for the most part, extra sinus most of the time, which minimizes complications. The complications, three of the main ones from a zygomatic implant placement, and that is ultimately is dehiscence of the implant itself, oral antral communication, and sinusitis. That's the trifecta that's absolutely potentially lethal to that whole therapy. And therefore, one has to be quite aware of that from the beginning, because again, if we are not, and we approach that implant placement, for example, from only there's bone, I pick my points, I drill, I place these long screws, and we're okay. That's carpentry. That's bad. And if it's taught that way, my goodness, we can teach a 10-year-old how to do even a sinus graft, for crying out loud. But the reality is there's obviously so much more to it. And honestly, with the zygomatic implant, there is a ton of things that need to be known, and principles, and you name it, not the least of which is a true prophylactic approach, as I see it, to minimize, not eliminate, but minimize that morbidity down the road, because these are patients, especially those who have severely atrophic maxillas, they end of the line. There's nothing more that can be done. Grafting is not even a thought. So it's a quad zygoma, two zygomas in each, two zygomatic implants in each zygoma, of course. And that is an art and a science in and of itself. And I give all the credit to so many folks, Dr. Aparicio, Dr. Dabo, both from Spain, Dr. Malavez. I mean, so many pioneers who really have brought us to where we're at today. But in a nutshell, the Zaga concept, zygoma anatomy guided approach, is a great one, because it's a prophylactic approach to placing these implants to minimize the problems that we can see down the road. So anything but a cavalier approach is important here, as I see it. And there's just so much I can talk about on that for hours and hours and days.
That will be done at your course, I'm sure. I look forward to attending it. I thank you so much for your time, Dr. Pikos. That was an amazing session, so much information to absorb for our colleagues. And I applaud you for what you're doing. We hope to have you back on the show in 2022 to see what else that brilliant mind of yours has invented or has come up with. And I really, really appreciate your time to contribute to our community of education. My pleasure and honor. Thank you so much. Thank you. Bye.